हाँ अभी रिफ्रेश करता हूँ एक बार. हाँ
How will you proceed? I will get an ECG.
हाँ हाँ मैं बात कर रहा है. बा आ गया ना. ओके मतलब हाँ हाँ ठीक है ओके सर. हाँ या श्योर सर. थैंक यू सर.
Good morning to all, respected faculties, my juniors, colleagues and my seniors. We will start today's presentation with a case. Dr. Salik sir.
A 45-year-old male patient presented with a history of hypertension diabetes came to the triage with complaint of retrosternal chest heaviness since 2 hours with associated diaphoresis and palpitation. How will you proceed?
So these are the vitals of the patient.
Heart rate is not.
Heart rate is it's like 90 per minute.
BP 110/68, respiratory rate of 26, SpO2 100% on room air. Normally you can see patient is having tachypnea and he have diabetes and hypertension with chest heaviness with diaphoresis, so he have some chest pain equivalents and chest heaviness.
Yes. So what is the first thing that you would like to get in this patient?
To get in, first of all I'd like to check immediately, since vitals are within normal, I'll immediately get an ECG. I'd like to see what is the ECG of the patient.
So this is the ECG of the patient.
So this is a standard 12-lead ECG. Details and speed and everything is not given. Going by rate rhythm analysis, like rate is around 60. Rate is around 60. Rhythm is regular. Rest the abnormalities, we can see some T-wave inversion that is present in AVL. There is some doubtful ST elevation that can be seen in 3. And AVF doubtful 0.5 box elevation is there. So this is a doubtful, like since there is inversion in AVL, you can suspect either there is an impending inferior wall MI or something of the sort.
Thank you so much. ST depression also in 1 and AVL.
1 also, yeah.
And AVL also there is a mild ST. Thank you so much.
Do you think that there is any ST elevation in lead 3?
Yes.
Yes sir. 3 minutes. 2
So 3 has a 1 mm ST elevation, but there is subtle ST elevation in 2 as well as in AVF. Together with a T wave inversion in AVL and ST depressions in 1 and AVL. So this is not matching our normal criteria of our STEMI, where we consider a 1 mm elevation in all the leads except for V2, V3, which has sex defined as well as age defined criteria. So in this condition, earlier we never used to categorize this as STEMI, and then these patients or these subset of patients were never going to get a reperfusion therapy, which could be or could not be beneficial for this patient unless we did an angiography to see if there is an obstruction or an occlusion in this patient. So we come to our topic, which is non-occlusion myocardial infarction. I am Dr. Harikrishnan S, Junior Resident, Department of Emergency Medicine, and my moderator for the topic is Dr. Jamshed Sir, Additional Professor, Department of Emergency Medicine. So actually what we are going to talk about is how we are going to change our thought process, obviously for the betterhood of a patient who is having a cardiac chest pain, from a STEMI and STEMI paradigm to something that is new to us, which is an occlusion myocardial infarction (OMI) and a non-occlusion myocardial infarction (NOMI). And the main purpose of a thought process like this is such that we have a reperfusion strategy, we have primary PCA, we have CABG and multiple interventions which can be beneficial to a certain subset of patients, and these patients are supposed to have some occlusion in their epicardial arteries, and this occlusion can be reperfused such that the patient will have a reduced mortality as well as morbidity in the future, reduced risk of any reinfarction, any risk of stroke, heart failure, and also life-threatening arrhythmias. So we will be going through what is an occlusion myocardial infarction and a non-occlusive myocardial infarction. Why was there a need for a paradigm shift in this acute myocardial infarction management that we are currently practicing? What is our basic approach to a non-occlusion myocardial infarction? Because our topic is basically NOMI and not OMI. Initial emergency management which shall be given to a patient of NOMI, any imaging as well as invasive therapy guidelines which have been proposed by both AHA as well as ESC. And also lastly, kind of new topic which is myocardial infarction with non-obstructive coronary arteries, which will also come under our non-occlusion myocardial infarction. So coming to occlusion myocardial infarction, so we have defined occlusion myocardial infarction as something that there is an ongoing ischemia in the heart which shall result in an irreversible infarction, and this is actually caused by either a complete epicardial artery occlusion or a near complete epicardial artery occlusion, which is usually, they say, more than 90% occlusion, which is causing an ischemia which will result in an infarction. And in this case, this artery is not having an adequate collateral circulation such that that particular area of our heart, that particular myocardium, will go into an irreversible infarction. And it is found that these patients are those subset of patients where when we do a reperfusion therapy, they will actually have a decreased mortality and morbidity. So the main concept of why we considered STEMI as our initial ECG criteria to identify such patients of acute coronary occlusion was such that there were some trials which were done in 1994 which was for thrombolysis, and they found out that it is this retrospectively it was done, and they found out that it is those subset of patients who are having a STEMI in their ECG where a ST elevation of more than 1 mm, and these patients were actually benefiting from a reperfusion therapy by thrombolysis and later on by a primary PCI or by our coronary artery bypass grafting. So it was these subset of patients that actually had some mortality benefit, whereas when we took the other subset of patient which was NSTEMI, which is non-ST elevation myocardial infarction, these patients were not benefiting from an increased morbidity or from a decreased morbidity or mortality, and these patients could actually get the same benefit by a medical therapy where we are giving a dual antiplatelet therapy or similar medications. So it was that is the reason why STEMI was introduced as our surrogate for an acute coronary occlusion in 2000 AHA or ASC guidelines. So this was the initial. Prior to the 2000 guidelines, it was a Q-wave paradigm where they did a retrospective study of those patients who were having an ischemic myocardial chest pain, and they found out that there were patients who were having a Q-wave on the ECG versus patients who were not having a Q-wave on the ECG. So they had something known as a Q-wave paradigm initially, but this was prior to our reperfusion strategies that we had via thrombolysis by streptokinase in that time, until 1994, where they had a study by the thrombolysis finalists of thrombolysis. There is a trial. So in that they found out that when they are thrombolizing a patient in this Q-wave paradigm, they found out that those subset of patients who had STEMI were the actual ones who were having an occlusion, and those patients were actually benefiting from this thrombolysis, whereas in the other subset it was mostly associated with an increased risk of bleeding. So the benefit risk ratio was less for the other subset. So then came by the year 2000 there came a STEMI paradigm, and this was actually going on until 2018, where a subset of patients were identified post retrospective analysis and systematic analysis and review that not all patients of STEMI are actually having an occlusion of your epicardial arteries, and there are some subset of patients in the NSTEMI criteria where they are actually having a total occlusion, and these patients are actually not getting any reperfusion therapy, and they are obviously going to get a reinfarction, they are going into cardiac heart failure, they could go into any life-threatening arrhythmias, and they have an increased morbidity and mortality. So the need for a paradigm shift from STEMI to something known as an occlusive myocardial infarction is very evident from this study. So coming to this paradigm shift, so initially, as I said, there was a presence or absence of pathological Q waves. So from that, they classified acute myocardial infarction as a Q wave MI or a non-Q wave MI. But in 2000, the ASA guidelines suggested that there should be a paradigm shift from a Q wave myocardial infarction to a STEMI and a non-STEMI, where there is a subset of patients with an ST elevation versus no ST elevation. And this is what we have already discussed, that some of the subset of patients in NSTEMI, they have an acute total coronary occlusion or a subtotal occlusion on the angiogram, and they were later evaluated because these patients were presenting again with an ischemic cardiac chest pain. So there was a meta-analysis that was done on the NSTEMI patients, and it was found out around 25 to 34% of the NSTEMI patients, they had an increased short-term, medium-term and long-term cardiovascular outcomes like a risk of reinfarction, the risk of death, risk of any stroke, congestive heart failure, and also any life-threatening arrhythmias. And this meta-analysis proved that even this subset of NSTEMI patients were actually getting neglected from our reperfusion strategy. And it has also been found that in those patients who are having STEMI, only 43% has actually an occlusion of the coronary arteries. So only 43% of STEMI patients are having an occlusion, and there is like 34% of NSTEMI patient who also has occlusion. So we need something that is going to group these two patients together. Hence came the paradigm shift, the need for the paradigm shift into something that is an occlusive myocardial infarction and non-occlusive myocardial infarction, and there are certain patterns of the ECG which could help us identify such occlusive myocardial infarction patterns. And there has been previous classes taken by Ankit sir and also our seniors which had taught us about the ECG patterns which is seen in an occlusive myocardial infarction. So I'll just show the patterns, but we won't be going into them in detail. So the fourth universal definition of myocardial infarction as per American Heart Association, they said that if there is an ST elevation of more than 1 mm in two contiguous leads, except in V2, V3, where the following cut points are done. If it is 2 mm in a man who is more than 40 years of age, 2.5 if the person is less than 40 years of age, and in women if it is 1.5 mm irregardless of the age. So this was the criteria that we were using until now, and based on this, together with a patient presenting with an ischemic chest pain, or together with a pathological Q waves on the ECG, or on echocardiography if there is any regional wall motion abnormality, or if there is on angiography there is an occlusion of a epicardial vessel, any one of this present, together with a raised cardiac troponin levels of more than of at least one value being above the 99th percentile of the upper reference limit, we would consider this to be STEMI, which was thought to be an equivalent of your acute total coronary occlusion. And then we will reperfuse that patient while omitting the NSTEMI patient where he will be left to suffer. So this is what happens normally on the ECG when a patient is having a coronary occlusion. Initially we will have a normal ECG, and then when there is an initial occlusion, from minutes to hours the patient will be having some hyperacute T waves, and then the ST elevation will come to set in, and then we used to classify this as our acute coronary occlusion. We used to reperfuse at this point. Later on the Q wave will start developing, ultimately the T wave inversions will come in, and later on the patient will go into an ECG pattern where there will be a pathological Q wave but normal T waves. And when there is reperfusion, we have certain patterns that was happening. So if this reperfusion is, because our body has a pathological mechanism where if there is a thrombus that is occluding an artery, our body will try to reperfuse that artery. So when that is happening, we had certain patterns like a terminal T wave inversion, which will be seen as a biphasic T wave, or it could be a later T wave inversions, and ultimately it will go into a deep inverted symmetrical T wave. So these patterns were recognized and these were studied, and it was found that these patterns were seen in a certain subset of patients who had LAD occlusion. So they named it as, so it was studied by Wellens, so it was Wellens type A and type B pattern, and this will also come under our occlusion myocardial infarction patterns where we should be vigilant, because these patients can go into a myocardial infarction which could actually be beneficial to do reperfusion in that subset of patients. So this was the initial blog that was actually submitted by Scott, Stephen and Pendle Myers, and this was actually the OMI manifesto that they had submitted, in which they were talking about the need for a paradigm shift from our normal STEMI and STEMI paradigm to something known as an occlusive myocardial infarction to not miss such patients. So ultimately we can come to a classification like this, where if we are having a suspected ACS, where ACS could be, initially we had learned it as STEMI and STEMI or unstable angina, it could be an ACS where there is an acute myocardial infarction, or it could be an unstable angina. And in our acute myocardial infarction, it could be either there is an occlusion in the coronary arteries that is resulting in an infarction, or it could be a non-occlusive myocardial infarction which will have some causes which we will cover up in the future slides. So in our occlusion myocardial infarction, we will be having a certain subset of patients who are having a STEMI positive and they are having an occlusion. Some subset of patients who are actually having a NSTEMI but they are having an occlusion myocardial infarction. Similarly, in non-occlusive myocardial infarction, there can be STEMI positive but it is non-occlusive. So these are actually the false positive STEMIs, and they can actually be a STEMI negative and they are not having an occlusion. So these are the subset of patients who are actually safe, and this is the main subset that we have had to actually be vigilant about. We need to do serial ECGs, because if they are not having a STEMI, mostly our cardiologists or they will also just say send a tropi and wait for it, and if the tropi is decreasing, you don't have to reperfuse or you don't have to thrombolyze the patient, you don't have to be scared. So these subset of patients require vigilant evaluation, not just their ECG evaluation, they need serial ECGs, serial troponin evaluation, and also clinical evaluation, clinical examination. Is the patient going into any shock? Is the patient going into any heart failure features? And then there are patients who are going to benefit from our reperfusion strategy. So this was that study that we were talking about initially, which led to a proper paradigm shift of STEMI to an occlusive myocardial infarction. So this was done by McLaren, and what they found out was that this is actually the shift that is happening from a Q-wave paradigm to a STEMI paradigm and ultimately to an OMI paradigm. And the same study that we had, so the numbers are the same. So basically they are saying that 56% of the individuals who had occulted arteries but did not exhibit ST elevation. They said that 43% of STEMI patients had an occlusion. So this was the reason why we actually need a paradigm shift from a STEMI and STEMI to an occlusive myocardial infarction. So these are the patterns in our occlusive myocardial infarction which had already been covered in the previous classes, and we're not going to go into detail about these patterns, but we need to make sure that we need to not omit such patterns in the ECG just because they do not have our STEMI criteria based on our 2018 universal definition of myocardial infarction.
So in your entire presentation, this is the most important slide, because these NOMI patients, non-occlusive myocardial infarction, so-called NOMI patients, basically they are the occlusive myocardial infarction. So you must remember this slide and just go and read about it.
So there is an article which I have kept at the last of it, which summarizes all these patterns, what is the most common artery that is involved in these patterns, and
I think you took it from recent publication in Annals of Medicine.
yes, about OMI, NOMI paradigm shift. So this is our OMI pattern. So we are going to go into a non-occlusion myocardial infarction. So when a patient of chest pain is coming to us, we will, as Alexa said, we will get an ECG done initially. We will see what is the pattern that we are seeing. Initially we will be keeping in our mind, is there a STEMI or not, but we need to broaden our thought process and we need to think about these patterns as well while evaluating such patients. Following which we will classify the patients. ESC says that we should classify them as cardiac, possibly cardiac or likely non-cardiac, rather than saying a typical chest pain and a atypical chest pain. They do not suggest the usage of such terms. They want it to be a cardiac chest pain or a likely non-cardiac chest pain. So the initial diagnostic tool that we are going to do is an ECG of that patient, and which should be done within 10 minutes of the first medical contact. So actually guidelines on non-occlusion myocardial infarctions are not present because this is a upcoming topic. So the 2023 ESC has guidelines on NSTEMI. The 2025 AHA also has guidelines only on NSTEMI, where they have also said that while we are tackling a case of STEMI, keep in mind about the STEMI equivalents, which are these occlusive myocardial infarction patterns. This is very important. So in this, just for a short period, I will be talking about the guidelines of NSTEMI because the other one is non-existent. But the management is, see, we can say that a majority of the NSTEMI patients will be having a non-occlusive myocardial infarction, where we got it around 30% are having an occlusive myocardial infarction. Such patients will be managed as a STEMI, where they are going to get a reperfusion therapy, primary PCI. So in the rest of the patients, what we are supposed to do is, so when the patient presents in, this is the normal ECG pattern that we are going to get. They can get a transient ST elevation, they can get a persistent or a transient ST depression, but keep in mind this should not be similar to the patterns of occlusive myocardial infarction that we have seen. Or there can be T wave abnormalities. These hyperactive T waves T wave inversion, this is actually mentioned in the 2023 ESC guidelines, where we should keep in mind that these hyperacute T waves are actually telling us that it should be an evolving myocardial infarction. So what we need to do is not directly reperfuse the patient, do not do that, but we need to keep in mind that this patient is there, this patient requires serial evaluation, this patient requires serial troponin evaluation, serial ECG evaluation, as well as clinical examination and the history of the patient. Is the patient having a cardiac chest pain right now when we are re-evaluating the patient, or if it is not present, together with if there is any ischemic ECG changes in the patient, if there is any rise in the cardiac troponin. So that is how we need to tackle every patient who we are considering to be a non-occlusive myocardial infarction or an NSTEMI. So basically what I have said, it is recommended that after the initial diagnosis and initial short-term risk stratification, we will come on to this risk stratification in the later slides. We are supposed to do a combination of history, symptom analysis, vital signs and other physical findings together with an ECG and together with a high sensitivity troponin. We are not just going to ask the patient, do you have pain? No, okay, you can go home right now. That is not what we are going to do. Do not do that to any patient who is coming. We give paracetamol or we give Panto when the patient's chest pain has settled and we are like, okay, it is a gastric cause of chest pain, I can normally discharge the patient. That should not be done in any of our triage. So as we are doing ACS, they had summarized it in the mnemonic of ACS, which is an abnormal ECG together with a clinical context that is suggesting that it is a myocardial infarction, and is the patient stable or not, which is based on the vital signs as well as the clinical examination of the patient. So coming to the biomarkers that they have suggested. So what biomarkers do is that they will do a complementary role in the diagnosis. They will help us in risk stratification and they will also help us in getting a proper idea of how to manage this patient who is having a suspected ACS, which could be STEMI, which could be NSTEMI, which could be just unstable angina. So the high sensitivity troponin assays are actually recommended right now because they have an increased diagnostic accuracy, where when we are repeating the high sensitivity troponin results, it is seen that the sensitivity is approaching 100%. And there are multiple algorithms. CSC has like 0 and 1 hour algorithm, 0 and 2 hour algorithm, 0 and 3 hour algorithm also. Here I guess mostly we will do a 0 and 3 hour algorithm, 3 hourly we are doing tropi, except in case that the patient is having a so severe chest pain together with some subtle changes in the ECG which is similar to our occlusive myocardial infarction pattern, then we will get an hourly algorithm. We will contact the cardio team for a reperfusion strategy of the patient. So cardiac troponins which are high sensitivity should be started within 60 minutes of our blood sampling, and we should obtain the results within 60 minutes of our blood sampling, and serial troponin measures which can be a 0-1 hour rule or 0-2 hour rule as per our ASA guidelines. So we can even go for a 0-3 hour rule in order to rule out rule in and rule out an NSTEMI. So this is the algorithm that was suggested by ESC, which is exactly the same thing that we have discussed right now. Coming to the initial care, so a patient came to you, the patient is having a chest pain. Dr. Shantimay, how would you want to proceed in this patient, as we have covered some part of it, in general? In triage, the patient, no, you are in the red counter, you have a patient who is said to have a chest pain and the triage doctor is somewhat doubtful about the ECG, so he had sent the patient because his chest pain is 10 out of 10 pain score. He is saying retrosternal chest heaviness he is having, 2 hours onset. So what do you want to do in this patient as you see him first in the red counter? No, he came immediately from the triage, like 1 minute. So you are saying you are loading the patient with aspirin and clopidogrel. Like, why are you loading the patient on aspirin and clopidogrel? What do you think that the patient is having? Is there any rationale for loading the patient initially on aspirin and clopidogrel? When, see, the patient just came to you, the patient is just saying that it is chest pain. ECG is somewhat doubtful. It is not a proper definition. By somewhat doubtful, I meant that it is not a proper definition of our STEMI. So you won't directly load the patient with aspirin and clopidogrel, right? Because you need to know if it is a cardiac chest pain or if it is a possibly non-cardiac chest pain first. So that should not be done. Not every patient should be loaded, but loading is not that harmful to a patient. If you are totally doubtful that if a patient is having a cardiac chest pain versus a likely non-cardiac chest pain, you can load the patient just to be on a safer side of the patient, because there is no risk in just loading the patient on aspirin, clopidogrel and your atorvastatin. So apart from that, what will we do? So you will re-evaluate the patient, you will see how his pain is responding. You need to give the patient some analgesic initially. Apart from aspirin, clopidogrel, they are not going to reduce the pain. So apart from that, you will get a repeat ECG. You might send a troponin when you are doubtful, and then you will see the initial value of the troponin, and then you will do serial evaluation of the patient, and then we will see if the patient is actually having something that is suggestive of an occlusive myocardial infarction or not. So thank you so much, sir. So considering oxygen, earlier it was all the patients who came with a cardiac chest pain thinking of STEMI or NSTEMI, they were put on oxygen initially, but it is recommended that only if the saturation is less than 90%, you have to put the patient on oxygen, because randomly putting the patient on oxygen is not going to be beneficial to the patient, and high flow oxygen can in some cases result in reactive oxygen species and a different pathway of problems for the patient. Apart from that, in case of analgesics, it is recommended to give nitrates or opiate analgesics. So nitrates, because it is going to cause vasodilatation, reducing the preload on the patient, so it should not be given in those patients who are preload dependent. Coming to opiates, so there is this one statement which was given in AHA that opiates may delay the gastric and intestinal absorption of our loading dose that we had given with our aspirin and our P2 Y12 inhibitors, and this might delay the pharmacological effects of such drugs, which could be beneficial to the patient. But there is no evidence as to this is being done by the opiates. So I would recommend you to give opiates if the patient is in severe pain and their pain is not getting relieved on nitrates, in conditions where nitrates are not contraindicated. So you can try opiates by morphine or fentanyl. I'll come to the dosage of it, because do not keep this theoretical statement in your mind and let the patient suffer in pain. But it was found out from a study that non-aspirin NSAIDs, they should be avoided, because these patients are actually having an increased risk of MACE, where they are getting an increased risk of reinfarction or they are going into heart failure. Because this was a study done on 2022, if I remember, 2006, where the risk of death and reinfarction was associated with the use of selective COX-2 inhibitors and NSAIDs after an acute MI. So we need to avoid using any non-aspirin NSAIDs drugs, because they have an increased risk of MACE. So this is the dose of analgesics that we give, which I hope that everybody already knows this. We won't be going into it. The only doubt was this morphine and fentanyl, but they could be given to these patients because although they said that we are delaying the gastric absorption, it is not proven. Coming to beta blockers, intravenous beta blockers, preferably metoprolol, should be considered, and it is whenever there is no signs of acute heart failure and if the BP of the patient is also normal with no other contraindications, you can consider giving a beta blocker to a patient. Primarily in those patients who are undergoing a primary PCI, because they have mortality benefit in such patients. They are associated with reduction in any life-threatening arrhythmias and also any microvascular obstructions. To not commonly, sir, but I have given in some patients but not in all patients. Sir, in case of an NSTEMI patient, sir, on discharging they are actually discharged on beta blockers as well, but not at presentation.
Sir, the mortality benefit that you are talking about is that
Long term.
if you give beta blockers within 24 hours
Yes.
of hospitalization, even if we don't give when the patient is taken up for cardiology, whatever, PCI or admission, that time they start the patient on beta blockers.
The question is, should we start IV metoprolol or something like that? Personally, I have seen few patients where there is a precipitous drop in the blood pressure for a reason which is not mainly because of the effect that it has on the heart. So, oral metoprolol or bisoprolol, carvedilol is perfectly fine. But many literature says that it reduces the chances of arrhythmias and microvascular complications.
coming to antiplatelet therapy, so it is recommended by AHA that in a patient who is having a suspected ACS, an oral loading dose of aspirin followed by a daily loading dose of aspirin is recommended, where the oral loading dose is 325 mg and the daily loading dose is 75 to 100 mg OD. It is recommended to reduce the death as well as the major adverse cardiovascular events. And in patients with ACS, an oral P2Y12 inhibitor should be administered in addition to the aspirin to reduce MACE. And in the recent guidelines of 2025, they are recommending ticagrelor or prasugrel as a class 1 recommendation. And if it is not available, or the patient is economically is unable to get it, or if it is contraindicated, then you can use a clopidogrel, because the chances of rebleeding is high in case of a ticagrelor. So the bleeding risk should also be evaluated in such patients, and this is the dose as it is given by AHA guidelines of aspirin, clopidogrel, prasugrel and ticagrelor. Only prior to patient going into PCA, we will load the patient with 600 mg of clopidogrel. I have once encountered a patient who was inadequately loaded with ticagrelor, where he received from an outside hospital 90 mg and he came here. So in any doubtful cases where the patient is not adequately loaded, you can reload the patient with what we have available here, which is aspirin, clopidogrel and atorvastatin, complete doses. Do not think that 90 mg of tica with, let's say, 150 mg of clopi might do the work. It is not going to. You need to adequately load the patient with a proper regimen.
Are we supposed to chew the aspirin or?
Aspirin, it is recommended that it should be a non-enteric coated aspirin, which is supposed to be chewed, which has the highest efficacy. But here we are not doing that because we do not have chewable aspirins. We have enteric coated aspirins as well, yeah. And we have it in a combination with atorvas, if I remember. Clopidogrel, if I remember. So we do not have chewable aspirins here. Sir, earlier also it was the same. Since 1 year, we never had it. We always have a combination also. So if we want to give 300 more of clopi, earlier, sir, 1 year back, I used to tell the patient to get it from outside. Abhi we have a separate clopidogrel so that we can load 300 more before the patient goes into a primary PCA in case of a STEMI patient.
And with regards to clopidogrel, and with age more than 75, do you want to stress on that?
Sir, if the patient, sir, that we are giving a reduced doses in the patients who are having.
Just put this tellate so that everyone is aware of.
So in case of clopidogrel, actually the loading dose is supposed to be 300 mg only if the patient's age is up to 75 years. So if he is less than or equal to 75 years, you are supposed to give 300 mg. When we are giving more than 75 years, you are supposed to give only 75 mg orally. So keep in mind when you are actually loading every patient with ACS 300 plus 80, that you need to consider the patient's age also into factor.
It's already written here also, prasugrel and ticagrelor also. If the age is more than 75 years or the weight is less than 60 kg, then you have to reduce the dose. So more than 75, reduce the dose.
So the loading dose of tica is 180 and that of prasugrel is 60 mg orally, just so that we know that if we are seeing such doses in an outside paper, don't get confused. So coming to the initial selection of our oral P2Y12 inhibitor, this is as per 2025 AHA guidelines. You are supposed to, in a patient who is going on to PCA, in case of an NSC elevation ACS or in case of a STEMI, you are supposed to give aspirin together with tica or prasugrel, which is the class 1 recommendation. And if these two are contraindicated or not available, then you can give clopidogrel. It is not a bad drug in the case, even in a patient who is going on bypass grafting. If there is no planned invasive evaluation, these patients will be discharged on aspirin together with ticagrelor. Again, tica is the class 1 recommendation that they are recommending, but clopidogrel can be used when tica is not available or it is not tolerated by the patient. The same thing in case of a patient who is undergoing hepatolysis in case of a STEMI. So coming to anticoagulation, the parenteral anticoagulation is also recommended in all the patients of ACS, irrespective of the initial treatment strategy. And this is such that we are actually reducing the risk of any recurrent reinfarction or any recurrent stroke, or if the patient is going to come again in heart failure and so on. So in order to reduce the MACE, we can give anticoagulation to these patients, and this is the dose of anticoagulations. So what they suggest is unfractionated heparin or low molecular weight heparin. In case you can use as an alternative to unfractionated heparin. And the dosing is given in this.
This also we don't usually.
In case of STEMI patients, we don't usually get a chance to give anticoagulant. The patients are quickly shifted to a cath.
So
So-
if you see the recommendation, even for patients who go to PCI,
We should
You are still give the case on loading dose, sir.
Cardiologists are not very comfortable with it, so we cannot give it. But once it's after PCI, they start the patient
So here it is.
because they are not comfortable. They feel that the bleeding risk will be there.
Bleeding risk
when
will
they are
be
doing
PCI.
PCI.
And in NSTEMI patients, we are usually, most of us will know that we are crossing the patient with the injection Clexane 0.6 ml subcutaneous BD. So in NSTEMI patients, after they are not having any ischemic chest pain, they are not going into a immediate PCI. The patient will be started on dual antiplatelets and also Clexane for 5 days.
60 to 80, and then the CT monitoring is very important.
And also, if as an alternative, you can use fondaparinux as well.
How long should we anticoagulate?
This anticoagulation, IV parenteral anticoagulation is usually given for 5 to 7 days, is what they say. They are saying the recommendation it is for 5 days you are doing this because that is going to reduce the risk of any reinfarction during that time period. Following which, the patient will be continued on the dual antiplatelet therapy with aspirin and either clopidogrel or prasugrel or ticagrelor. So remember the same thing of the age in case of 75 years is our important thing. 75 years and 60 kg, that should be kept in mind. So there are certain things that we are going to do in a patient who is having a non-ST elevation MI. We are talking about NSTEMI just because
loading the patient of a STEMI patient who is going for PCI is perfectly fine. ठीक है ना? But what about unfractionated heparin or low molecular weight heparin when the patient is undergoing fibrinolytic therapy or thrombolytic therapy? आपका take क्या है? There are multiple studies also suggest that it increases the risk of hemorrhage, ICH and something like that.
Yes, sir. You mentioned that as well. You mentioned about anticoagulation for fibrinolysis that you avoid before thrombolysis.
so that was recommendation it is given, sir. What they say is do not give fondaparinux.
But I think the bleeding risk is more. We should be careful with it.
PCI, it's perfectly fine. Thrombolytic therapy, मुझे भी थोड़ी problem है.
Sir, specific guidelines on AHA on anticoagulation on fibrinolytic therapy is not there. Studies I haven't seen, sir. Specific criteria for anticoagulation in a patient who is undergoing fibrinolysis is not there. As far as sir. Only for PCI patients, avoid fondaparinux.
Patient going for primary PCI, it's okay. Thrombolytic therapy, cautious.
Yes, sir, chances of bleeding. So in a patient who is not having an who is not having an occlusion in their epicardial arteries, should they get an angiography? Should we evaluate them for seeing whether the patient is supposed to get a PCA or not? This is based on the STEMI and STEMI paradigm, which is, and the guidelines are on the 2023 ESC guidelines, where who you should get an early coronary angiography, where early was defined as less than 25 hours from the diagnosis of the ACS or from the first medical contact. And those patients who are getting a selective invasive approach, where they will get a coronary angiography, they can get a PCA if there is an occlusive epicardial artery, or if not, they won't. And this is based on clinical assessment and any other risk stratifications. So this is the selective invasive approach versus a routine invasive approach in the patients, and the guidelines are on the patients who are having NSTEMI. So what they say is that we will first, when we get a patient who is having a likely a non-occlusive myocardial infarction, I suggest that we should risk stratify the patient, and they will be stratified as high risk. One is very high risk, in which the patient is in either cardiogenic shock, or if the patient is having any life-threatening arrhythmias, or if the patient is having so much heart failure. So these patients should be given immediate primary intervention. That is clear-cut rule that is there. That is a level 1 recommendation. Any patient that you see in rhesus who is post-STEMI or post-end-STEMI, he is in cardiogenic shock. Who is in cardiogenic shock, we are supposed to shift the patient to the cath lab for primary intervention, but the shifting process is difficult because the patient is anyways in cardiogenic shock. He is not improving on your inotropes, and I have personally managed 4 patients who are in cardiogenic shock post an MI KC4 classification, and these patients all succumbed in our research itself because we could not shift the patient because the patient was not maintaining on dual inotropes. So anyways, while we stratify such patients, we will be having some high risk patients which we will go into. So these patients should be getting a routine invasive strategy.
Why these patients are not shifted?
Sir, patient was going into multiple cardiac arrest.
Suppressor or inotropy support would work in these patients?
No. Sir, why sir? That is why. So, sir, during shifting they might go into arrest, so after stabilization they would want to shift is what they usually say. And we can't, NORAD is not going to help such patients. ADR infusion also won't help. So, and most of them had biventricular failure, so nothing will help. We can't give Lasix to decongest the patient because the patient has low BP. We can't give NORAD to increase the BP because it is not working. Yeah. And in those patients who are at a low risk of ischemic events, they can get an either invasive approach if they are having recurrent anginal chest pain. If not, they can get a selective invasive approach. And this is basically why are we doing all this? So that we are reducing the major adverse cardiovascular events that the patient might get in the future. Everything that we are doing, everything that we are studying, STEMI and NSTEMI is just so that we can identify that subset of patients who we can in emergent treatment save their life. That is our main thing, why we are changing the paradigm, why we are doing all this. So this is what is suggested in AHA, that a routine invasive versus a selective invasive strategy in such patients. So same thing that we have discussed, if the patient is high risk or intermediate risk, we will do a routine invasive strategy which is within 24 hours that the patient came into the hospital with the symptoms of ACS, and if they are having an occluded coronaries, we can get a PCI or CBT depending upon the severity. If not, they will get medical therapy, which is your dual antiplatelet therapy together with anticoagulation. The patient shall be discharged. Selective invasive is usually done in those patients who are having low risk. Then they will be undergoing some stress testing, and then we will see if they are getting recurrent ischemic symptoms. If that is present, they could get a routine invasive strategy. If not, they will also be discharged under medical therapy. So for risk stratification, when a patient actually presents to us, we have multiple scoring systems which can be used. One more score is there, EDAX, which is ED assessment of acute coronary syndrome score. So these are the base scores which have been validated, which can be used in such patients in order to see if they are at a high risk of death, recurrent myocardial infarction, recurrent hospitalization due to an ischemic cardiac chest pain, if they are at a risk of heart failure or recurrent stroke. So we have a gray score, heart score and TIMI score. The TIMI is thrombolysis and myocardial infarction. Heart score is as its variables are, and gray score is global registry of acute coronary events. So this will tell us, the gray score will tell us about the in-hospital mortality as well as the 6-month mortality. Heart score is for short-term evaluation of the patient if he is going to get a MACE within 6 weeks, and TIMI score has 1 week and 6 weeks. So I will be coming into it. So this is the gray score. It looks very complicated, so I usually do it with the MedCalc. But we have multiple variables in this: age, heart rate, systolic blood pressure, creatinine levels of the patient, the KC classification of the patient at presentation, any history of congestive heart failure. Are you able to see? Yes. Cardiac arrest in admission, which has a high history of MI, and the patient having elevated cardiac markers. Then we have the heart score, which is there in our tropi form on the side, which most of you would have done, except for troponin you cannot fill because you are sending it for tropic. The rest of it is history age of the patient, ECG age risk factor. So this we can fill it, and we will see if the patient is, can the patient be discharged home because there is no short term risk in that patient, or should we keep the patient in triage or in the red counter and evaluate further. So anything of 4 or more is actually a high risk, and we should evaluate that patient, and 7 or more means that the patient requires an early invasive strategy. So I actually suggest all my juniors to actually use this in the triage, so that you actually have an idea and you will be safe as to your discharging the patient off at home on tablet PCM and tablet PANTOP SOS. So this is the TIMI risk score. So TIMI risk score is also having this. Actually, this TIMI risk score is there for STEMI as well as NSTEMI. So this is the one that we use for NSTEMI, because for NOMI nothing is valid. So it has age more than equal to 65 years, 3 risk factors of CAD, which could be a hypertension, diabetes, if the patient is a smoker, if the patient has a family history, if there is dyslipidemia in the patient. Non-CAD. So what they say by stenosis more than equal to 50%, will be coming on to it, because when we are saying that the patient's artery is stenosed, we mean that it is either 50% stenosed or more than 50% stenosed. We are not talking about less than 50% stenosis. And also in aspirin use in the past 7 days. Coming to recent severe angina, so they have defined severe angina as 2 or more episodes in 24 hours. Together with increased biomarkers or an ST deviation of more than equal to 0.5 or no, which could be elevation, which could be depression, and then we will stratify the patient in order to see if there is any risk of death or MI, as well as any urgent if the patient requires an urgent revascularization or not. So all this was actually we were talking about that subset of a non-occlusive myocardial infarction. So we have one small subset of myocardial injury patients. We will go on to that. Just before that, so this is the same thing but summarized. If the patient is very high risk, if the patient is in cardiogenic shock, refractory angina, if the patient is having any life-threatening arrhythmias, or if the patient is having any signs and symptoms of heart failure, you need to do it immediately within 2 hours, same as that of a STEMI patient. Take this patient and you need to reperfusion. So when we do a Grace risk score, if the Grace risk score is more than 140, then these patients are also at high risk. So these patients will also get a routine invasive strategy where we will do a coronary angiography within 24 hours, which was discussed earlier. Intermediate risk will be a Grace score of 109 to 140. Such patients will also get Grace at high risk or intermediate risk. We will be giving a routine invasive, and in all the low risk patients, we will be doing a selective or invasive based on the stress testing and other things, and also other risk stratification. So when we are talking about myocardial injury, so again, so we had STEMI and STEMI, then we had OMI, NOMI, we are getting a similar thing, MyCAD and MINOCA. So
actually, why we are discussing these things, non-STEMI patient, lot of research has been made in the past, and multiple trials are there, and you just go and read about these trials. One is the TMAC trial, more than 3,000 patients. Then there is a verdict trial, then there is the ELISA 3 trial, then there is a one more trial which is large trial. I think
so Verigo also.
So lot of trials are there, and there is a meta-analysis which was published in the European Heart Journal with 17 randomized controlled trials. So they actually pulled data of all those trials, more than 10,000 patients were there, and they tried to find out is there any benefit in non-STEMI patient for early revascularization. So the results were not good actually. Basically all of them actually touching the midline. So risk ratio was slightly decreased, but obviously if you send every patient of non-STEMI to cardiac cath lab and results are not so good, then it is a burden to the intervention radiologist. The only benefit that they got, that recurrent ischemia was slightly less in those group of the patient, which was statistically significant. So they came to a conclusion that only in a subset of patient it is beneficial. So what he is describing, that high risk and intermediate risk, actually they came from those studies only, the Grace score and cardiogenic shock and everything. So that is from those studies.
So coming to 2 more added abbreviations. So in case of a myocardial injury, this myocardial injury can be strictly cardiac, where the epicardial arteries are completely obstructed. this is causing your ischemia, which will later go on to go to your irreversible infarction, which can give your STEMI or your occlusive myocardial infarction. That is known as myocardial infarction with an obstructive coronary artery disease. So this is the majority of the patients who are having a myocardial infarction. There will be some small subset of patients who are not going to have this. They are not going to have an occlusion in their myocardial epicardial arteries. So there is something known as a myocardial infarction with a non-obstructive coronary arteries. So what happens in these patients is that when you do an angiography, let's say if you are going to do an angiography, there will not be an obstructive coronary artery in these patients. But still,
long press it will turn on, short press it will turn on.
so these subset of patients where there is myocardial infarction with a non-obstructive coronary arteries, they are not going to have an obstructive coronary artery. So you are not going to reperfuse them randomly because they do not have anything to reperfuse because they are getting proper reperfusion. But still, these patients are suffering from a myocardial infarction, which could be because of a plaque, an atherosclerotic plaque, which is not completely occluding the blood flow in that artery, or it could be because of spasms in that, or it could be something that will be in a even microscopic level of microvascular spasms, microvascular dysfunction that the patient have, or it could be spontaneous coronary artery dissection. It could be a type 2 MI, which most of you would have seen in patients of hemoglobin of 3. When you get an ECG just because they are having sinus tachycardia, you would be seeing widespread ST depression in these patients. You would be scared, you would send a trope, the trope is coming positive. These patients are having myocardial infarction, but they do not require reperfusion. They actually require reversal of what actually caused it. It is a supply demand mismatch just because they are having very low hemoglobin levels. So the amount of oxygen that is reaching these myocardium, it is actually less, even though the flow and everything is perfectly fine. So then came the concept of something known as myocardial infarction with non-obstructive coronary arteries, and in the last Saturday class, Jamshed sir gave us an insight on what it is with the case. So this could be one thing, and then there is a small subset of patients who are having non-ischemic myocardial injury. So these are actually known as Minoca mimicus, and we will just go into it, and Dr. Faisal will teach us about that in his coming presentation. So coming to Minoca. So what is Minoca? So it is actually that the patient is having symptoms that is suggestive of ACS. So patient came with a chest heaviness, patient came with a chest pain, patient has so much diaphoresis, there could be radiating chest pain. So you did an ECG, the ECG is coming normal, still the patient is having ongoing chest pain. In such cases, it is not getting treated on your analgesic, so it is a refractory angina pain, and you are going to get a troponin to see if there is any myocardial injury. The patient has troponin elevation, so there is something happening with the myocardium. There is actually an ischemia that is there in the myocardium, which is sufficient enough to actually raise the cardiac biomarkers. And then when you do coronary angiography, which is not usually done except for our EHS patients, I hope, you are getting a non-obstructive coronaries. Even the case that Jamshed sir gave us, it was a nursing officer who was having a subtle elevation troponin, and she underwent angiography. What I personally think is that I think at least half of the patients who we are seeing as STEMI, they might have myocardial infarction with non-obstructive coronary arteries, but they are not getting their routine coronary angiography from this hospital, so we do not know about that. Anyways, they are having some myocardial infarction with a troponin elevation, and they do not have an obstructive coronaries at the time of coronary angiography. So why are we focusing on this is that there was one systematic review and meta-analysis which told us that there is around 3 to 15% of acute myocardial infarction are actually Minoca, where there is not obstructive coronary arteries are not present in these patients. So that is why we are discussing this topic as well. So what are the trends? So Minoca, as sir has already said, see, it is usually as compared to that of your obstructive coronary arteries, it is seen in younger patients with a median age of 61 years. I am not saying 61-year patient is young. Compared to Micra, this is younger. Sir is not here. So, and also it was found that Minoca, they were less likely to present with your traditional risk factors that you had which I had already discussed, hypertension, diabetes, these patients will not have such history and all, and they were disproportionately, it is affecting the females. Is the same meta-analysis has told us that the reason why it is affecting disproportionately in females is because the causes of menarche, which we will go into, is commonly seen in females, which we don't know why, but yeah. So in case of menarche also, these patients shall have ST elevation on their presentation, and they might be treated as STEMI, but then we already said that these patients may 3 to 15% might be menarche. They can have non-ST elevation. The problem is the same thing as your OMI. In non-ST elevation menarche patients, they are at an increased risk of long-term CVS related hospitalization, because they are actually not getting the proper treatment that they require. They are non-ST elevation, so they are just discharged off. They are not getting routine evaluation, and they will come back again with the same hospitalization. Again, they will not be having an ST deviation, so they will be discharged again, they will come back again. So this is going on in a cycle. So this was actually found out in a Chinese study, and they found out that it is the non-ST elevation menarche that is having more, that is actually causing more problems in our society rather than ST elevation, because we are treating the ST elevation menarche. So the diagnostic criteria of menarche is the same as, so we will be having a fourth universal definition of our MI criteria, which was already said, troponin levels above the 99th percentile of the upper reference limit, together with your either symptoms or new ECG changes or QAs or regional bone motion abnormality or angiography, you are getting an occlusion. Just remember that in case of menarche, in this angiography you should not be getting an occlusion. So that should not be there. It should be non-obstructive coronary arteries on angiography. Together with that, you need to rule out other causes of type 2 MI. These patients should not be having very low hemoglobin, that is causing a supply demand mismatch, or these patients not having a, so those subset of patients of type 2 myocardial infarction are also excluded, and then we can say that this is a clear cut case of myocardial infarction with the non-obstructive coronary arteries. And actually there is not much guidelines on menarche as well, but in 2018 AHA has said that there is a subset of patients, and you need to keep this in mind. Although the treatment of our, based on our concern, it is the same. For us emergency physician, the treatment is the same. You are going to load the patient if he is having an MI features, and then you will call your cardiology, you will see if the patient is going into shock or not, manage that. That is our main thing. But how we should approach, and we can't just randomly see a patient and we can say that patient does not have any changes on the ECG, patient is menarche. You cannot say that. So you need to have a systematic approach. So this is known as a traffic light sequence for the diagnosis of myocardial infarction with non-obstructive coronary arteries. So initially we came into this diagnosis because the patient is having a rise and fall of more than 99% plus ischemic chest pains, and the patient is not having an obstructive CAD on the angiography, which the patient might have had earlier if we are dealing with that patient. You need to think about alternative causes of elevated troponins, which could be sepsis or PE or any cardiac trauma, or other non-cardiac causes could be your type 2 MI causes, like supply demand mismatch because of anemia or hypertension. So after this red light has been cleared, we will come to this yellow area where we will be thinking, did we miss some obstruction? This is mostly by the cardio team, not our emergency team. If they missed some obstruction, and is there still ongoing myocardial injury? So if this is there, we would review the angiographic findings. You can get an LV function assessment. Why we are doing is such that these subset of patients are actually having not menarche, they are having something known as menarche mimicus, which is actually a non-ischemic cardiomyopathy that the patient has. So then when this is also been cleared, we will come to our actual item, because there is nothing else that the patient can have. So we will come to a diagnosis of myocardial infarction with a non-obstructive coronary arteries. In this we will do multiple studies, we will come on to these, and then we will find out if the patient is having what cause of myocardial infarction with non-obstructive coronary arteries. So this is known as a traffic light sequence. So coming to the causes of menarche. So functional flow reserve, coronary flow reserve, CFR is coronary flow reserve, FFR is functional flow reserve, if I am remembering correctly, ma'am. I am not that complete. I will go on to coronary flow reserve soon. Coming to menarche causes, one thing is that there is an atherosclerotic plaque, that plaque can undergo rupture or that can undergo disruption, so that could be one of the cause. Another thing is that there is epicardial coronary vasospasm. So most of you would have heard of vasospastic angina or Prince metal angina, that you would have heard of. Is that Minoca? That is not Minoca. So what happens is that if that is severe enough to actually cause a myocardial infarction, then you can classify that as Minoca, because this is all myocardial infarction. So apart from that epicardial coronary vasospasm, the other causes could be either a coronary thromboembolism, or it could be a spontaneous coronary artery dissection (SCAD), or it could be CMD, coronary microvascular dysfunction. Then coming to these non-ischemic causes of Minoca, which is termed Minoca mimicus, there could be myocarditis, Takotsubo cardiomyopathy, which is your broken heart syndrome, and there could be non-ischemic cardiomyopathy, which could mean your restrictive cardiomyopathies, dilated cardiomyopathies, hypertrophic cardiomyopathies, arrhythmogenic cardiomyopathies, and so on. So the same causes just listed upon here. So we will go on to this one by one shortly, and we will end our presentation. So coming to plaque, so there is an atherosclerotic plaque, and it actually includes either plaque rupture or plaque erosion, or it can be calcified nodules. Ultimately these plaques will undergo calcification. So this is actually restricting the flow in the coronary arteries, but always remember that this flow restriction is, or they are causing a stenosis, but it is less than 50%. Always remember that in case of Minoca, the coronary restriction is happening, it is less than 50%, because if it is coming more than 50%, you will consider it as a myocardial infarction with an obstructive coronary artery disease. So there are multiple studies on Minoca, and which is basically observational studies, and they have found out, like, each of the studies have different factors as the most common cause. So we cannot say that this particular thing is the most common cause. So as per the HARP study, they found out that they found out that plaque disruption was the most common cause, but it is not that relevant, because there is not a single cause which you can say that Minoca is caused by that particular condition. So female sex and smoking history are associated with increased risk of plaque rupture. Then we go into coronary vasospasm. So in case of coronary vasospasm, what they say is that when there is coronary vasospasm, it is actually causing a vasoconstriction which is more than 90%. So then it is known as a macrovascular vasospasm. So this is actually causing a compromised myocardial blood flow, which is leading to your ischemia, which is leading to your infarction. And we have multiple testing for this as well. So what this provocative testing with acetylcholine means that, so what acetylcholine does is, it does a dose dependent action on the endothelium of your coronaries. So when you are giving an intracoronary infusion of acetylcholine, let's say at a dose of 2 to 20 micrograms, then what happens is that it will cause endothelium vasodilatation. And when you are giving a higher dose of 100 to 200 microgram, it is going to cause vasospasm. And when it causes vasospasm, it will affect both your both your large epicardial arteries as well as your small microvascular arteries. So when that happens, if it is happening for more than 90%, you can say that this patient is having a diagnosis of coronary vasospasm. This patient is having a diagnosis of and we have one cause of Minoca coming to coronary vasospasm and how it is diagnosed. Coming to the next causes. So next one is spontaneous coronary artery dissection. I won't be going into much details about every cause. We will be seeing the coronary flow reserve function tests as well as a provocative testing, which we had already gone into. So spontaneous coronary artery dissection means that the patient is spontaneously getting a false lumen within your epicardial coronary arteries, and this is in the absence of atherosclerosis. There are actually 4 types of SCAD that has been described. So this is basically seen when you are doing an angiography. So if there is multiple radiolucent lumens that is staining within the arterial wall, it is type 1. Type 2 is diffuse smooth stenosis. So as the type 3 is such that there is focal stenosis, and this will be mimicking an atherosclerotic plaque causing atherosclerosis, causing the obstruction. And type 4 is a total vessel occlusion. So this is also most commonly seen in young women who are presenting with an ACS or sudden cardiac death. Our other causes include coronary embolism. So coronary thrombus or coronary embolism, which results in Minoka if it involves the microcirculation. So
How is this different from our typical type 1 MI, coronary thrombus and
this is not going to, so type 1 MI you are saying the obstruction is not going to be more than 50%.
an embolus cannot stay if it, like, how can an embolus
In the
come from
microvascular system it is causing. This is all based on the, this is all on the microcirculation. We are not talking about your LAD or LMC or RCA and all. Because if it is going there, we are supposed to reperfuse that patient, it will cause a STEMI, it will involve a much larger area, and all that is going to happen. This is all when this thrombus is actually present in a microcirculation. And finally, the coronary microvascular dysfunction. So when I am saying this microcirculation, it is actually those coronaries who has a diameter of less than 0.5 mm. And this is actually more than 70% of your coronary arterial resistance is caused by this micro coronaries, and that is why this is actually very important in such cases. So if the patient is having an ischemic chest pain, if it is a non-obstructive coronary arteries, and then we will do so in the same way as we did an acetylcholine provocative testing or an ergonovin provocative testing, we will do the same testing, and if it is actually affecting less than 90%, it will be a microvascular spasm, and if it is more than 90% spasm, it is macrovascular spasm. That is how they have defined coronary microvascular spasm and coronary macrovascular spasm. So if that is also negative, then if the patient is having an ischemic chest pain, non-obstructive coronary arteries, then we will do something known as a coronary flow functional tests, which I will go into, and then we will diagnose if it is a coronary microvascular dysfunction or not. So this is the synopsis of what these testing were. Acetylcholine provocation testing we have already seen. So how we do is we give an intracoronary infusion of, initially we will give a low dose to see if there is dilatation. Then this is preferably given in the left anterior descending artery. Then in order to induce vasospasm, you will give a high dose. Now the patient has vasospastic angina, anginal chest pain. So how to reverse it? Always is princemetal angina or vasospastic angina, it will be responsive to nitrate. So we will give 200 micrograms of nitrates, nitroglycerin. Following that, you will give adenosine to the patient, intravenous adenosine, which will cause dilatation of your coronaries. And then you will study certain parameters, and then based on their threshold values, we will diagnose it as coronary microvascular dysfunction. So one of the things is this coronary flow reserve, CFR. So it is actually the ratio of, so when you are giving this adenosine, it is going to dilate your coronary, so you will get hyperemic flow. So that hyperemic flow velocity divided by the baseline flow velocity, which is measured by your cardiac Doppler or thermal dilution, you will get a CFR. And if that CFR is less than 2.5, they say that it is because of a microvascular dysfunction. So around 2.5 to 4 is the normal value of the CFR that is going to come. So if it is coming less than 2.5, it is a coronary microvascular dysfunction if the patient is having non-obstructive coronaries together with an ischemic chest pain. Other parameters you can see is, one is hyperemic microvascular resistance reserve, and index of microcirculatory resistance. These are not that
This is not important for emergency.
for emergency patients. So
Just what is Minoka and how to evaluate. You can suggest the cardiologist that you have to go and do this.
So these are, you can read about this if you would want to, but yeah, I'm not going to explain this. No sir, angiography is required.
So knowing these details will not really help.
Why was it?
Not Viva, because
If you answer every question, then if you answer this also, you might get a gold medal maybe.
So for you, any patient of STEMI and Minoka,
regarding this CFR, IMR,
in that context, like even the
That is why I just wanted to
Minoka is to be clear.
Sir, 2 more slides.
let him finish Taskatam.
I just included it so that if you see this anywhere, don't get scared. You had listened it in Hari's class, you can remember.
This now is only scary, isn't it?
You might see it when you prepare it for your maybe.
I will simplify.
Then type 2 MI, just touching upon it, everybody knows this, it's systemic supply demand mismatch, and you know the various causes that can cause. So actually what happens is, because of the supply demand mismatch, there will be an elevation in the troponin, which is satisfying your, which is fulfilling your fourth universal definition of MI. Coming to Minoka mimicus, there are 3 of them. I won't go into detail of all of this. So Takotsubo cardiomyopathy is there, myocarditis is there, and non-ischemic cardiomyopathy is there, and it is better to get a cardiac MRI to see, because this cannot be diagnosed without a cardiac MRI, and this is the gold standard for diagnosing myocarditis is cardiac MRI, where there will be diffuse edematous pattern on the myocardium.
In biopsy, bacterial basic procedure, you may not get diagnostic sample in basic procedure. You can easily diagnose with CMI. So now, tell us criteria, or because biopsy is not done. You used to say that it is.
Sir, I read in an article about Minoka that MRI was the gold standard. That is why I said.
Now CMI is gold standard.
Diagnostic modality, we had already gone through it, just naming it for you. So one is your coronary intravascular imaging based on your angiographic ultrasound or coronary optical coherence tomography. Cardiac imaging, you will do an echocardiography, because in that, if you are getting an apical ballooning of your left ventricle, it is a Minoka mimicker, it is your Takotsubo. Cardiac MRI for Minoka mimicus specifically. And then coming to this invasive functional studies, which we already know what is the provocative spasm testing and the CFR, as well as IMR, HMR and MMR. So this is the summary of what cardio people are supposed to do in case of a patient comes with Minoka. We stop here. After that, it is all done. Same thing that we had discussed, nothing new. They had written CFR less than 2, because in some guidelines they say it is less than 2, and some of it say 2.5. The last article says it is 2.5. So I suggest taking 2.5, although it is not that important for us. Coming to the management strategy of Minoka should be that the cause should be managed. So that is why these patients are actually coming back again with an ischemic chest pain, because the cause is not being addressed. Mostly the subset of patients who are not having an ST elevation in case of Minoka. So just for you to go through, nothing much. If the patient is having a plaque rupture and all, you will treat the patient same way as it is a plaque related MI. You will give the patient DAPT, can give the patient PCA if there is so much unstable plaque or multiple areas of small plaques. In case of spasm, the first line drug is calcium channel blockers. You can give your nitrates also, they will respond to nitrates as well. In case of SCAD, you can give DAPT, beta blockers, PCI if the patient is unstable. In case of a microvascular dysfunction, again statins, ACE inhibitors, CCBs, beta blockers, because of the mortality benefit that the patient is going to have. In case of an embolism, antiplatelets and anticoagulants. Then the other Minoka mimicus, and they should be managed with the GDMT. Our basic thing is supportive management for such patients if they are presenting in failure. Same thing, just a summarized one. The trials about Minoka, last 2 slides. Trials about Minoka is such that none of them have been published completely, and there are not much trials on Minoka, so it is an upcoming topic. So one thing they did was just seeing clinical characteristics of those patients who had Minoka, which is due to atherosclerotic. What you asked, Salik? Atherosclerotic causing Minoka, why is it not type 1 MI, you asked? So there is atherosclerotic Minoka versus non-atherosclerotic Minoka, and how these patients are actually differing in their clinical characteristics, and they found out that those patients with an atherosclerotic Minoka, they are at an increased risk of death, MI, stroke, rehospitalization and so on. So this is just a random trend that they did in these patients of Minoka. Whereas non-atherosclerotic, where your SCAD can come, your spasm can come, or it can be an unclassified cause. This is one trial that is ongoing right now, the PROMISE trial, which is a precision medicine versus standard of care therapy in myocardial infarction with non-obstructive coronaries. So this is ongoing, there is no result for this trial. So what their plan was, they will take these Minoka patients, they will randomize them. So what their standardized therapy that they are doing is they will do OCT, they will do acetylcholine test, ultimately coming into a cause. They will find out the cause, then they will give the tailored pharmacological approach. versus the standard treatment of discharging the patient with your GDMT. So the sample size is 180, they have recruited 120 patients, they have stopped recruiting and they are now analyzing the patient. They will actually do a follow-up of this patient for 12 months. 0, 6 and 9 months when they will call the patient, and at 12 months they will call him to the OPD and then they will evaluate the patient with angiography and they will see the primary endpoint, the quality of life, and the secondary endpoint of any infarction, stroke, or heart failure and so on. So this is ongoing right now, the PROMISE trial. There is one more trial, the Minoka batch trial. So this, they randomize the patients to receive either beta blockers plus ACE inhibitors, beta blockers alone, ACE inhibitors alone, or none of them. So for 1:1:1:1 randomization. So in this study they had a total sample size of 3,500. They got like 127 or something patients. This study was started in 2021. So in 3 years they got 100 patients. So they kind of stopped the trial. They stopped inclusion. Now what they are saying is the results are not there because they are analyzing these 100 patients, which is very slow. But the plan was 3,500, they did not get any because they cannot include these patients. So this is also, they hope that the result that they are going to publish will be beneficial for future guidelines. I don't think so. So this is the third trial that was there in case of Minoka. The rest of it are all systematic review, meta-analysis as well as observational studies that they have done just to see who it is more common, in what race of patients. It is more common in black and Hispanic patients. I forgot to mention that. Thank you.
Hari, excellent presentation, well researched actually, and you tried to capture almost everything which is available in the literature on Minoka. So Minoka is something that emergency physician should know about it and how to evaluate rather than going into the details, because you will not be able to diagnose Minoka in the emergency department. Now a lot of confusion is going on worldwide that whether STEMI, non-STEMI parameters should be used to actually give treatment in the emergency department or shift the patient to cath lab, or NOMI is a better way to go. So the patient should be either thrombolized or go to the early catheterization. So my opinion is very simple, that if you see the details of angina, STEMI equivalent which is written there, that if there is some ST depression, reciprocal ST changes in AVL1, then probability is inferior or myocardial infarction. We all know about the reciprocal changes in the chest leads in the posterior valve myocardial infarction. If you see various patterns, for example, South African black sign, a Slanger pattern, there is some ST elevation in some lead. There is some ST elevation in AVR. My take-home message for all of you is that even if it is not fulfilling the criteria, that is the voltage, the millimeter criteria of a STEMI, but assess the patient and apply your brain. Assess the patient. If you think that my patient is complaining continuously about the chest pain and the things are worsening, for example, patient is complaining about the chest pain, that there is no relief of chest pain. And the troponins, if you go delta troponin, it is increasing, or some dynamic changes are there. Patient, there is some ST depression was there, suddenly there is some ST elevation is there. So you have to apply your brain to activate the cath lab. In NOMI, occlusive myocardial infarction versus NOMI will not work. Probably, I think it will not work, because it is very difficult to understand in the emergency department that it is OMI or this is NOMI. So whatever actually non-STEMI where the patient is very high risk, for example, patient in cardiogenic shock, patient in who is electrically unstable, this patient in heart failure, patient is in heart failure actually, or patient not refractory pain, severe chest pain which is refractory to your treatment, GRACE score, heart score, then you apply all those score, and again these patients will be occlusive and these patients should get early intervention. So this is the take home message. Otherwise अगर मैं आप अपना ECG को retrospectively study करोगे ना, कि ये पेशेंट नॉन स्टेमी था, उसको कैथ अगर आपके पास अवेलेबल है कि एवरी पेशेंट विल गो टू कैथ लैब, then you retrospectively study some changes will lead to कि भाई this pattern will be more towards occlusive myocardial infarction. Probably it will not work. That is why ACC/AHA is thinking twice, thrice that whether it should be included in the guideline or not. So दिमाग अपना अप्लाई करना है. अगर मरीज़ ऐसा लगता है कि इसको जाना चाहिए with a reason, then you should activate the cath lab. एंड दिस इज़ ऑल्सो वैलिड फॉर द कार्डियोलॉजिस्ट कि भाई ऐसा नहीं है कि मिलीमीटर क्राइटेरिया फॉलो नहीं कर रहा पेशेंट तो उसको ऑक्लूसिव मायोकार्डियल इन्फॉक्शन नहीं है. एंड वन थिंग विच इज़ वेरी इंपॉर्टेंट that this occlusive MI, despite the fact that they are not fulfilling the millimeter criteria of ST elevation, their mortality, morbidity is almost the same. Thank you very much.
വേണ്ടത്. Good morning everyone, I am Dr. Mohammed Faisal, Junior Resident Emergency Medicine. The topic for today is sudden cardiac death. My moderator is Dr. Bharat Sir, Assistant Professor Emergency Medicine. So let's start with the definition of sudden cardiac death. So as per the American College of Cardiology, sudden cardiac death actually refers to the unexpected natural death from a cardiac cause, usually occurs within 1 hour of onset of symptoms in a patient without any prior condition that would be fatal. According to the European Society of Cardiology, the definition is similar. They also tells that it is unexpected death due to cardiac cause in a patient with or without cardiac disease. But again, the time duration is within 1 hour of onset of the first clinical symptoms. So if the arrest is witnessed, then the cutoff is 1 hour, and if it is an unwitnessed arrest, according to the definition, it is within 24 hours also. We can call it as a sudden cardiac death. So coming to what is sudden cardiac arrest. Sudden cardiac arrest is something that leads to a sudden cardiac death. So as per this definition given by Buxton et al., it refers to sudden cessation of cardiac activity which results in the victim becoming unresponsive with no normal breathing and signs of circulation. And if the corrective measures are not taken rapidly, it can lead to sudden cardiac death. So again, this is sudden cardiac arrest. So this condition is usually reversible if we are given timely CPR and defibrillation, and post-stroke if it is cardioversion or cardiac pacing. This whole thing can be reversible, and this definition does not include events that are non-fatal. Coming to the epidemiology, this is actually a data from 2019. So it shows that the most mortality due to sudden cardiac death usually is in the United States. In Indian data, in India they have only taken age groups of more than 35 years, and in rest of the countries they have included data in all age groups. So coming to the etiology, obviously the most common cause of sudden cardiac death is secondary to a coronary artery disease, which occurs in about 75 to 80% of the cases. After CAD, the second most common causes that have a cardiomyopathy can be hypertrophic cardiomyopathy, dilated cardiomyopathy, or arrhythmogenic cardiomyopathy. And the other less common causes are like the channelopathies, which are like Brugada syndrome, long QT syndrome, early repolarization syndrome, and the least common causes are that of congenital heart disease and valvular heart diseases. So this is actually a population-based study. It is in the Indian context. It was done in 2012. So they've just found out that the sudden cardiac death is usually it contributed to 10.3% of total mortality. The mean age was 60.8 plus or minus 14 years, and majority of them were within the age group of 50 to 70 years. Out of that, 38% of the people had coronary artery disease, with 17% of them had acute MI. Out of the patients, 80% of the patients had risk factors for cardiac event like hypertension, smoking, or diabetes. This is another study, observational study done in India only. It's regarding the prognosis of the out of hospital cardiac arrest, and they have assessed 123 non-traumatic out of hospital cardiac arrest who received bystander CPR. In that case, bystander CPR was given in 8% of cases. So out of that, the overall survival rate was only 0.8%. So with this data, this was published in 2024. So this shows that the prognosis of OHC, out of hospital cardiac arrest, is still very dismal in India. And also the proportion of cases in which bystander CPR was given, that is also very less, only 8.1%. So this is just a small data which shows a real world problem. National Journal of NJEM, not NEJM. हाँ नहीं एक ऑथर इज फ्रॉम बैंगलोर वो आ रहा है सर अभी. This is another study conducted by our seniors, Rajna ma'am, Angit sir, Roshan sir. So they have also analyzed the pre-hospital out-of-care cardiac arrest victims in a tertiary care hospital. So they have analyzed 205 patients, out of which only 9.8 patients had received bystander CPR. So out of that, AED was used only in 1% of cases, and ROSC was achieved in 8.3% of the cases, which only out of that only 1.4% patients survived till discharge. So again, the outcome of this study also, still the outcome of out of hospital cardiac arrest in India is very dismal. So there is a need to improve awareness regarding layman CPR, so that we can hope to improve these numbers. Coming to the yes. Coming to the pathophysiology, see, the basic mechanism behind all the sudden cardiac death is that these patients will develop some underlying arrhythmias due to any metabolic abnormalities or myocardial ischemia or infarction. That will lead to ventricular tachyarrhythmia or asystole, propagating the sudden cardiac arrest cycle. So again, there is interplay between the arrhythmogenic substrates and transient events which leads to this condition. So most of the episode of sudden cardiac death as per data occur in the home, but if they occur in the public places, there is more chance of survival, of course due to bystander CPR and involvement of AEDs. So also it is found out that the initial rhythm, if the patient is in public place, if he is exercising or walking, then there is a more chance that the initial rhythm will be a shockable rhythm. because the patients who are in experience cardiac arrest at home, they usually are debilitated patients or chronic diseases they have, or old patients. So in that case, they have not found initial rhythm to be a shockable rhythm. Coming to the risk factors, obviously the first and foremost risk factor will be this coronary artery disease and all the risk factors associated with that. Then severe LV dysfunction, cardiomyopathy, valvular heart disease also contribute to the avoidable causes. Then hereditary causes like channelopathies, Brugada, early reporterization, QT, long QT, short QT, and long-term risk factors like hypertension, hyperlipidemia, smoking. These all can lead to CAD, can in turn lead to sudden cardiac death. So these are all the risk factors. So it has been observed that usually the patient will develop myocardial infarction usually in the morning, and CPVT is catecholaminergic polymorphic ventricular tachycardia. So that patient or those subsets of patients also, in the morning there will be high surge of cortisol and catecholamines. So these usually occur in the morning. And Brugada syndrome, the typical history will be patient will be sleeping and suddenly they will wake up due to chest pain or palpitations. So Brugada syndrome usually it is found to occur in night. Coming to the predictors, in a patient with risk factors, how can we predict the risk of sudden cardiac disease death? So if the patient is having any CAD, coronary artery disease or cardiomyopathy, with the patients with LV ejection fraction less than 30, wide complex on ECG monitoring, the QRS complex is more than 120, they are predisposing to ventricular arrhythmias, and if the patient has a history of cardiac failure or prior arrest, and then in some case of channelopathies, if during monitoring, if the patient is found to have more than 10 premature ventricular complexes, and if the patient is had a recent MI within 6 months. So all these basically all these cases will conditions are can predispose to a sudden cardiac event. So we'll start with the case. In that case, like in such patients, it's an indication for ICD implantation more than. Dr. Krishna Priya, can you read the case? So, can you read this ECG? This was obtained shortly after the ROSCO was achieved.
There is ST elevation in 3 areas with ST depressions in 1 area.
What it is suggest? Sit. So, that was a typical case of coronary artery disease. As per the data, they found out that in sudden cardiac death victims, out of that 80% of them on autopsy had coronary atherosclerosis, and people who survived, maybe they found out that who underwent CTCA, they've also found 70 to 80% of cases associated with coronary artery disease. So management post-ROSCO. Dr. Mahima, what is the loading dose which you usually give in suspected STEMI patients? Dose? Which statin? Okay. Take it. Sit. Dr. Mahadev, PCI versus fibrinolysis. Patient as post-arrest ABI. Patient is M6. What is the strategy? PCIs. No, sit. Dr. Yahya, what is the window period for fibrinolysis? So window period of fibrinolysis is 12 hours. Okay. And Dr. Salik sir, is there any evidence for thrombolysis during arrest? So far we've not have any data for fibrinolysis during arrest. But in some cases, if the cardio people are not ready to take the patient, we'll try with 50 mg alteplase IV stat. That is what we do. But even though evidence are not there. So this is a trial, COAC trial. It stands for coronary angiography after cardiac arrest without ST elevation. So this actually shows that patients who were successfully resuscitated after an out of hospital cardiac arrest with shockable rhythm with no signs of STEMI or non-coronary cause, in such patients there is no role in doing an immediate angiography, because like it is immediate and delayed angiography provided almost the same results. There is no mortality benefit of doing an immediate angiography, especially if there is no ST elevation. Similarly, another trial, also Tomahawk trial, it also deals with whether we want to do early angiography in OHCA patients without ST elevation. But in the previous trial, they only included shockable rhythm. But in this trial, they've included shockable as well as non-shockable rhythms. The outcome was also same. There is no mortality benefit of much difference in doing an early angiography versus routine angiography. Coming to the heart failure, the best current predictor of sudden cardiac death is the patient of LV heart failure with LV ejection fraction. The cutoff is less than 35%. So such patients, how can we prevent cardiac arrest? What we have to do is that we have to take the patient for implantable cardioid defibrillator, because that is how the sudden cardiac death can be reduced. So again, the indications for this ICD implantation in such patients are ejection fraction less than 35, wide QRS more than 120, and even if the patient is given GDMT, the still patient is NIHA class 3, class 4. So in such patients, the definitive treatment to prevent sudden cardiac death is that of an ICD implantation. So these are all the major trials which were done over the years. MADIT, MADIT2 trial, all these trials have shown that compared to the GDMT, that is the standard treatment, versus the ICD implantation, ICD implantation has shown to reduce mortality in most of the studies. So these are all the studies which were done in the last decade. So yes, so the current evidence is ejection fraction less than 35% in any heart failure patient. They are candidates for ICD implantation to prevent sudden cardiac death. Coming to the cardiomyopathies, they include 10 to 15% sudden cardiac death, the most common being hypertrophic cardiomyopathy. Initially, we'll talk about DCM. In DCM, what happens? There is dilated ventricles. They promote dispersion of the ventricular depolarization. So inside that chambers, there will be islands of ventricular tissue to depolarize. So there will be re-entry phenomenon, and in this case, there is sustained ventricular arrhythmias. And let's see another case. Dr. Saurav, read the case. Okay, ECG. So what are you seeing in this ECG? Look, any peculiar thing you can notice? So, yeah, biphase cleavage you can see. Okay, sit down here. Dr. Anuvind, any peculiar thing you can see in the ECG?
So in the leads of 2-3 AVF, and also in lateral we can see like the dagger.
What are they called as? Dagger cleavage. Okay.
And it also it's like LVH features.
LVH. So what, any clue on what's the diagnosis? Okay. So next we'll be dealing with the HCM. HCM is still the most common cause of sudden cardiac death in young adults, and it is a genetic condition, autosomal dominant cardiac myocyte disease, where there is mutation in the beta myosin heavy chain protein, which codes for the contractile machinery of the heart. So as per the data, per year the risk of death increases at the rate of 1%. And earlier it was called as HOCM, hypertrophic obstructive cardiomyopathy, but now it's like most of the cases it is obstructive, but 1/3 of the cases it is non-obstructive. So how do we diagnose on an echo? See, echo diagnosis is by the left ventricular wall thickness more than 15 millimeter or more, with a septal wall divided by posterior wall thickness. The ratio should be more than 1.3 in normotensive or over 1.5 patients, 1.5 in patients who are hypertensive. And even though it is not, even if it is less than 15, if there is a positive family history of any sudden cardiac death or for LVOT obstruction, that is we can see by the gradient, or if there are any ECG abnormalities like the dagger Q waves or LVH, that can also point towards a diagnosis of HCM. And that gradient which we see, that we usually see the apical 5-chamber view, we put continuous wave Doppler at the LVOT, and the gradient should be more than 30 millimeter. And it has been found that a gradient of more than 80 millimeter has a risk of sudden cardiac death. Sir, last made so this is the typical LVOT tracing which this is also called as dagger sign of echo. So we have dagger Q waves as well as dagger sign in LVOT tracing. So the basic pathogenesis is there is dynamic LVOT obstruction. So first there is an increase in septal thickness. So the septum will narrow the LVOT, and there is something called as SAM, septal anterior leaf, systolic anterior motion of the mitral valve leaflets. So what happens is usually during systole the mitral valve will close. So whereas in HCM the basic pathophysiology is that during systole the mitral valve will move anterior, and that will lead to the obstruction of the LVOT. This is called as a dynamic obstruction. So this SAM actually has 99% specificity in diagnosing HCM, and the other mechanisms are obviously there is hypertrophy which leads to diastolic dysfunction. That will cause secondary MR. So these are the other mechanisms involved. So this video is not playing. So So this in echo we can see that clearly there is thickening of the this is the LV, this is the LV. So this is the thickened LV freehold, and the video is not playing. So during ventricular systole there is the mitral valve will go and hit the LVOT. So it will obstruct the LVOT. So there is dynamic outflow tract obstruction, and that is a basic pathophysiology in HCM. So the most common arrhythmia in HCM is atrial fibrillation. So what happens in HCM? There is no proper diastolic dysfunction, diastolic filling. So the ventricle depends upon atrial systole for ventricular filling. So in case of atrial fibrillation, the atria is not contracting properly. So there is further reduction of preload. So see, in this case, mostly 35% of the LV filling depends upon the LA contraction. Here the LA is not contracting properly. So an arrhythmia in HCM patients can be deadly because there is severe reduction of preload causing decreased cardiac output and hypotension. Second common arrhythmia is non-sustained VT. It is present in 20% of the cases. This can progress to ventricular fibrillation, and the most common cause of sudden cardiac death is arrhythmia due to ventricular fibrillation. So the arrhythmia basically occurs due to myocardial ischemia causing myocyte disarray. So again, the management general consensus we tell them.
How will you risk stratify patient who is having HCM that they are at risk to develop sudden cardiac death?
Sir, family history of
One is a family.
then recurrent syncopal episodes or for chest pain.
When the patient is doing exercise, there is a drop in blood. Anything else? Gradient,
Recurrent syncopal.
gradient more than 60 millimeters.
Gradient more than 80 millimeter of mercury. For this LV thickness more than 30 millimeter. That is an echo.
Or if there is inducible VT.
On electrophysiology study included. So the general consensus is that we tell them to avoid competitive sports, because what will happen? On exertion, the patient will have tachycardia. Tachycardia will further worsen, because in tachycardia what will happen? There is decreased time for diastolic filling. Already diastolic filling come here. So if you are or exerting, then there is severe reduction in preload, and it can worsen the LVOT obstruction. But a trial, it was that live HCM trial, and they found out that even in patient vigorous exercise Carnivale patients, they did not it did not lead to higher death rate in or life-threatening arrhythmia compared to moderate exercise or sedentary life. But still, the recommendation is to avoid competitive sports. Further trials are necessary. So again, adequate hydration, as this condition is preload dependent condition, adequate hydration is recommended. And beta blockers are the first line. Again, beta blockers will reduce the heart rate, increase time for diastolic filling, increase the preload. And non-dihydropyridine CCBs like dilixam and verapamil we can give, because they also have nodal depressant effects. They also AV nodal blocker. They also reduce the heart rate, thereby helping in this condition. Diuretics actually they reduce the preload. So can we use them? No. But in case of non-obstructive HCM with refractory fluid overload, we can use. But again, you have to use them judiciously. Routinely, they are not used. Again, avoid vasodilators. Why? Because they reduce the preload. Dihydropyridine CCBs are notorious for causing reflex tachycardia, and they do not have negative inotropic effects, AV nodal blocker effects, so they are also avoided. The mortality reduction is by implantable cardioverter defibrillator, and as per this data, 50% of them will be refractory to medical treatment, in which surgical treatment will be the option. LVOT grade, as per this article, they have written that LVOT graded more than 50 mm with NIHA 3-4 symptoms despite GDMT will go for surgical intervention, and the intervention is septal myectomy is more preferred than alcohol septal ablation. Coming to the how can we predict? Basically, if the patient on risk stratification found out that the patient has high risk for sudden cardiac death, what will we do? Obviously, we will go for an ICD implantation. So the patient is having prior documented cardiac arrest, or if the patient is history of hemodynamically significant or NSVT, then if there is a family history of sudden cardiac death, or if any first degree relative has that, then it is a high risk. Then multiple episodes of unexplained syncope. This is the echo criteria. The diagnostic criteria is more than 15 mm thickness, but if it is more than 30 mm thickness, there is severe diastolic dysfunction. So in such patients also, ICD implantation is recommended. LVOT graded more than 80 is not, it is not an indication for, but because the patient is at risk for SCD more than 80. Basically, if it is more than 50, 60, we can consider ICD implantation. Coming to a case. Dr. Nandakishore, read the case. So tell me what is marked here, what is being. There is actually a small blip after the QRS complex. What is? So this is a characteristic epsilon wave. So we are going to discuss about arrhythmogenic right ventricular cardiomyopathy. So what happens is that it is also a genetic condition in which the right ventricle is mostly affected. The myocardium of right ventricle is replaced by the fat. So it leads to right sided heart failure causing ventricular arrhythmias. So again, this patients also can present with recurrent syncope, palpitations, and can lead to sudden cardiac death. So again, normal myocardial muscle if there is fatty deposition. Usual age group is 20 to 40 years. Most common presentation is palpitations. 20% cases usually patient presents with first cardiac arrest, so usually they go undiagnosed. And the arrhythmia, they usually involve ventricular arrhythmias, non-sustained VT, VFib. Initial presentation, most of them will be having a ventricular tachycardia as their stable VT as their initial presentation. So evaluation, as we see in the ECG, apart from the epsilon waves, there is also a precordial T wave inversion in V1 to V4. Along with the epsilon wave, the
What is the commonest finding?
sir, clinically,
What is the commonest ECG finding?
epsilon wave is usually not present in all the cases. Symmetrical T wave inversion is V1 to V4,
Epsilon wave is more specific.
but it is not.
Synthetic is the
T wave inversion is V1 to. So epsilon wave has high specificity but low sensitivity. Echo may we see obviously the right ventricle is defective, so there will be enlarged or hypokinetic thinned out RV with trabeculations. Those trabeculations are actually the fatty infiltrates that we can see. The diagnostic test is cardiac MRI, and endomyocardial biopsy is also given. This is the echo, it's not playing. As you can see inside the right ventricle there are trabeculations. So and the RV wall is thinned out. So this is what is seen in what you see in ARVC. Coming to the management, again in such cases also exercise can lead to lethal arrhythmias. Antiarrhythmics, they have recommended class 3 antiarrhythmics. Sotalol, it is not class 2, class 3. Better than metoprolol. We can also consider amiodarone. So again, this patients also we can consider. We have to do ICD implantation, preferably single chamber, because only the ventricle RV is affected. So VVI, ventricle inhibition. If the patient is having refractory or incessant VT causing frequent discharges, radiofrequency ablation is recommended. And the definitive management, it has shown to improve benefits is cardiac transplantation, because the RV free wall is affected, fatty infiltration. So cardiac transplantation can be a definitive management, as it has shown to improve the survival rates. Again, when do we put implant ICD? There is a history of cardiac arrest or symptomatic VT not responding to medication, or during EP study if there is inducibility of ventricular tachycardia, or severe RV dysfunction with poor tolerance to VT, and if there is frequent episodes of NSVT and recurrent syncope, and family history, sudden cardiac death of a first degree relative.
I'm sorry, basically it is ARVT or ARVC, but can involve both the ventricles.
Usually
Right ventricle followed by biventricular,
followed by left ventricle.
then isolated left ventricle also. That is why we are not
Calling it as cardiac
using right ventricle
display size cardiac.
and there are chances that ventricular outflow of RVOT, VT, LVOT, VT is more complicated.
Coming to sick sinus syndrome, it's actually a sinus node dysfunction. Basically what happens is that usually due to genetic conditions there is histologic degeneration of the SA node. So it is Lenegre disease and Lave disease. Lave disease is there is fibrosis of the bundle branches, and there is Lenegre disease means there is idiopathic sclerodegeneration of the AV node and bundle branch block. So basically these conditions will reduce the conducting system of the heart. So usually the most common ECG finding is sinus brady, then can cause occasional sinus pause or sinus arrest, then exit block. Something called as a tachybrady syndrome is also been seen in such cases. So this is a typical ECG showing initially there is bradycardia alternating with tachycardia. So this is characteristic of a sick sinus syndrome. So in such patients also the symptoms are same: fatigue, lightheadedness, pre-syncope and syncope.
What is the definition for sinus arrest?
Sinus arrest if the pause is more than 3 seconds. That is less than 3 seconds sinus pause. So first always rule out the electrolyte abnormalities like hyperkalemia, hypocalcemia. Then if everything is normal, evaluate for other causes, like it can lead to infiltrative causes like amyloidosis, sarcoidosis, and it can also be a complication of drugs like beta blockers or CCBs. Again, exclude the reversible causes. ECG may have a constellation of findings. It may be sinus brady, sinus pause, or sinus arrest. The initial what we can do is that outpatient monitoring with Holter, and if it is failing to show any arrhythmia, then implantable loop recorders can be given. So again, there is a constellation of ECG findings. Mostly they are bradyarrhythmias more than tachyarrhythmias. Tachybrady syndrome can also be seen. Gold standard is the rhythm monitoring. Again, if ILR shows nothing, we have to do the EP study. Treatment is dual chamber pacing, and these are the indication. Documented sinus brady with frequent pause. Symptomatic chronotopic incompetence means the failure of the body to increase the heart rate during exercise or exertion. If the patient's heart rate is not adequately increasing during a physical activity, that is, and the patient is having symptoms, that is called as chronotopic incompetence. Then symptomatic sinus brady, if the patient is taking a medication for heart rate control, in that case also ICD implantation is needed. Failure to increase the heart rate by at least 80% of the required heart rate.
80% from the
above the baseline. So Kirtana ma'am, can you read the case?
When we made the no wave is presented complaints of sudden onset heart rate followed by
Simple. So what is the ECG? What?
even showing no test, even in weekly there is no test.
So what is the so next we'll be discussing about the hereditary channelopathies, out of which we'll be discussing all these 5. We will start with the Brugada syndrome. Again, Brugada syndrome is an autosomal dominant due to the mutation in the it's actually a sodium channelopathy, mutation in the sodium channel, and it predisposes the young individuals to malignant arrhythmias. It usually occurs in the night. There will be a classical history that the patient will be asleep, woke up by sudden chest pain or palpitation. So that will be the typical history of Brugada. And earlier the diagnosis was based on ECG and clinical criteria. So we will be looking at them now. So as the ECG showed, there is a coving of coved ST segment elevation, but the cutoff is more than 2 mm in more than or equal to 1 lead of V1 to V3 with T wave inversion. And type 2 is saddleback ST elevation, again more than 2 mm in V1 to V3. It is suggestive of Brugada, but it's not diagnostic. Only type 1 is a diagnostic pattern of ECG. Then type 3 is a mix of type 1 and type 2, but there is less than 2 mm ST elevation. The other condition there were more than 2 mm. Again, clinical criteria, there are some clinical criteria to remember. If the patient is family history of any sudden cardiac death, or if family members there is any type 1 ECG pattern, or if the patient had a documented arrhythmia like VF or polymorphic VT. Again, I told night symptoms like nocturnal agonal respiration or unexplained syncope, or during programming ventricular stimulation if the patient had demonstrated inducibility of VT. So such patients also can we have to consider Brugada syndrome, but that, according to the latest guidelines, for definitive diagnosis they are not considering the clinical criteria. They are only considering the symptoms. Symptoms means like chest pain or palpitations or syncope with type 1 Brugada pattern in at least one precordial lead, specifically in V1 or V2. It is not telling more than or equal to one lead. Only one lead may coved ST elevation plus symptoms. That is according to the 2013 HRS Heart Rhythm Society guidelines. Or other type 1 nahi hai. If there is saddleback ST elevation in more than or equal to one right-sided precordial lead under baseline conditions and following a sodium channel blocker challenge, the sodium channel blocker given usually flecainide 1C, or there is one drug called as ajmaline that is usually used in the US. It is not available now. So these sodium channel blocker challenge may, after giving, if the ECG is converted into type 1 to type 2, then it is also diagnostic. But if it is type 2, we we need to have at least one clinical criteria, which we discussed earlier.
What will happen if you give another?
Sir, the sodium channel blocker it will exacerbate the condition, and the type 2 ECG will be converted into type 1 ECG. Brugada, saddleback will be converted into coved ST elevation. So that is called a sodium channel blocker challenge. It's used in the diagnosis of.
If your patient is not having
But,
type 1 or type 2.
There are 3 different types of Brugada. But the one there is
Coved ST elevation. More than 2 mm V1 to V3.
And there is a saddle
Both.
So how and when it will help?
If initially, if the patient is, it's actually an outpatient test. We don't do it in the emergency. If the patient is having type 2, any suggestive of Brugada other than type 1, if the patient is asymptomatic, if we give a sodium channel blocker challenge, the literature says that the ECG.
There is a YouTube podcast by Mr. Amarman. He very much very beautifully described that if we were the thing will happen. What are the two things? Is it what he said that if we were nothing will happen. So these patients are safe. Okay? Second patient, if you give aspirin, there will be polypharmacy type of feedback. Yes. So you are already doing in the EGS lab, so you will just give it like a second. And the third is there is an increase in the ST elevation. Increase in ST elevation and some patient who develops PT, these two patients are in.
So these are the diagnostic criteria of Brugada. Management, again, avoid sodium channel blocker, and in such patients, minor fever like infection or any infection can trigger malignant arrhythmias. So what happens is that in Brugada there is sodium channelopathy, so there will be overactivity of the potassium channels. So what happens is that there will be a voltage gradient created. So initially the epicardium will repolarize and then endocardium will repolarize. In such patients, what will happen is that there will be early repolarization of the epicardium than earlier than usual. So there will be a voltage transmural voltage gradient which is created. That is a basic pathophysiology of Brugada syndrome. So in patients with any sudden onset infection or fever, they actually tamper with this voltage gradient and they've shown to trigger malignant arrhythmias. So again, in such patients, how can we prevent sudden cardiac death? ICD. So basically all these conditions, to prevent sudden cardiac death, the basic thing to do is that implantable cardioverter defibrillator. They have also shown that in case of electrical storm, they have recommended quinidine, but quinidine is a class 1A drug. It is also sodium channel blocker. Then why it is used? But it is also more than sodium channel blocker. It is also a potassium channel blocker. It blocks the transient outward potassium current. So earlier, due to the sodium channelopathy, the potassium channels are overactive. So this quinidine will block the transient outward potassium channels, and this will reduce the transmural voltage gradient between the epicardium and the endocardium. That is related. It actually targets the pathophysiology of Brugada syndrome. So basically, we can use quinidine for rate control in such patients. Coming to the risk of sudden cardiac death in Brugada syndrome. So if the patient is symptomatic, recurrent syncope, recurrent palpitation, or inducible VT on EP study, or if the patient is having a very short ventricular refractory period, or if the patient is having after exercise testing, if the patient is having increased ST elevation, this exactly I'm not sure, they've written in the article ST elevation in the recovery phase of exercise. So this also point towards the risk of sudden cardiac death. So coming to ICD, again, indication of ICD, if the patient is symptomatic with aborted SCD, aborted sudden cardiac death matlab, the cardiac arrest has been aborted due to an intervention or spontaneously. So such patients who had a history of cardiac arrest, again they require ICD. Symptomatic patients with documented VT or multiple syncope episodes also require ICD. That is class 2A recommendation, whereas the patient is having type 1 ECG with syncopal episodes also class 2B recommendation. And if the patient is asymptomatic on programmed ventricular simulation, if there is arrhythmia like VT or VFib, then such cases also we have to consider ICD implantation. Coming to the next case, Dr. Yedu.
18-year-old female, no prior comorbidities present with chief complaints of multiple episodes of syncope. The following ECG was obtained. The ECG, the rate is normal around 60, rhythm was regular, P waves are there, there's no widening, QT is prolonged.
Yeah, So let's discuss about long QT syndrome. First of all, how can we look for QT prolongation in a normal ECG? How do we know that on eyeballing? How can we see that it is QT prolonged? So basically, look at the between the RR intervals. So if the QT is more than half of the RR interval, then roughly we can have an estimate that the QT is prolonged. But this only occurs, it is only possible if the patient is having normal heart rate. If the patient is having tachycardia, it will overestimate the QT prolongation, and agar brady hai to underestimate the QT prolongation. So this is actually a diagram I have taken from Litchfield. They properly from T wave ka we have to draw a slanting slope. From there only we have to measure. And if the patient is also having U wave, we should not consider U wave. Till T wave ka end only we have to see. Coming to the types of long QT syndrome, type 1 is having broad base with tall T waves. Type 2 is having additional low amplitude T waves with additional hump or notch. Type 3 long QT syndrome mein there is ST segment lengthening. So again, clinical fact features syncope, family history of sudden cardiac death. Diagnostic criteria, if the QT is more than 500 millisecond on repeated ECGs, or if the patient is having unexplained syncope without a secondary cause, still QT is more than 480, or genetic testing mutation hai, but a score called as Schwartz score is used. Not, we don't routinely do, just know the name. It has clinical history, ECG findings and family history. So if it is more than 3.5, it is diagnostic of long QT syndrome. Coming to the management, there is long QT syndrome, so we should not again avoid the QT prolonging drugs which can provoke the exacerbate the condition. Usually long QT syndrome, again before diagnosing long QT syndrome, first rule out the basic things: hypokalemia, hypomagnesemia, and then correct them. And they found that beta blockers are again effective responding to long QT syndrome 1. And since the long QT syndrome type 2 is having sort of flat T waves, so more risk for hypokalemia. And avoid strenuous exercise. Again, when will we do ICD implantation? Patient survived cardiac arrest, patient with syncope despite adequate medical management, or if the patient is having very long QT, more than 550, or if the patient is having alternate amplitude of high and low T waves, T wave alternates in ECG. So these are all the indications for ICD in long QT syndrome. Coming to short QT syndrome, again there is less than 340 millisecond of QT interval corrected. Patients are usually asymptomatic, can have palpitations, pre-syncope, syncope. ECG typically showed there is actually absence of ST segment, it's very small, and there will be tall T waves. So that this is like you can identify there is QT to high nahi, so it is QT short nahi. So such patients also they've considered potassium channel blocker, quinidine. There is short QT, so potassium channel blocker will widen the QT, prolong the QT. So they've considered pharmacological treatment with quinidine. Again, definitive management by ICD, recurrent VT, prior arrest. There is a family history. So definitive management of this condition to ICD. Coming to catecholaminagic polymorphic VT. So this is also a channelopathy. Basically results from mutations in the calcium channels which cause increased intracellular calcium levels, causing delayed after depolarization and triggered activity. So since it is catecholaminergic, any emotional or physical stress can lead to the release of catecholamines, can trigger VT. There is a high risk of electrical storm. Electrical storm means more than or equal to 3 episodes of VT in 24 hours. So ECG criteria also, usually we are seeing frequent premature ventricular complex, VTs or bidirectional VT. So this is actually ECG initially showing ventricular tachycardia. Beach mein you are seeing bidirectional VT, ek upar ek niche. So again there are many different morphologies of VT in such patients. Management beta. Sir, digoxin toxicity. CPVT.
Sometimes you can get in ACS, but they conite toxicity
Aconite. Management is beta blockers preferred nadolol over propranolol. Such patients, if they are getting agitated, then there is more risk of sudden arrhythmias happening and sudden cardiac death. So sedation is, there should, in such patients there should be low threshold for sedation and intubation, because anxiety or distress can trigger arrhythmias. So flecainide has been shown to reduce the release of calcium from sarcoplasmic reticulum, class 1C antiarrhythmic. So it has also been used.
This is a condition which is very difficult to diagnose in the emergency department, because the patient will come with some symptomal attack. When you do ECG, is completely normal. If you are fortunate enough, sometimes you may get PVCs and biometric, something like that. But it's very difficult. So you should have a very high index of suspicion to diagnose. It is really difficult.
So definitive management, sympathetic denervation can be tried. Here SGB, cerebral ganglion block, can be tried in refractory VT, which we usually do if it is electrical storm during cardiac arrest. So in such cases also we can try SGB. And if chronically the patient is having, after diagnosing the patient is having chronic arrhythmia, surgical sympathetic denervation has been used. Then if it is refractory to beta blockade or surgical treatment, we can consider ICD implantation. So this is it. Salik sir will read the case.
If our baby presented to ED, with on-and-off chest pain for 4 to 5 days,
So the chest pain is basically a 2 out of 10 chest pain. So this is the ECG. Young patient, atypical chest pain. So basically there is ST elevation. Initially we might think it is MI, but we have to see the J point. There is fishhook appearance. Such patients usually come with 25-year-old patient came with chest pain. You will have such things and you will think that it is MI, but it's usually ERS. Now it was used to be called as BER, but now we are referring to it as ERS, early reportation syndrome, because they found out that there are case reports that BER is not so benign. So usually it is a normal pattern seen in 1 to 2% of the adults. So these are the ECG criteria. Widespread concave ST elevation with fishhook appearance at the J point, and ST by T ratio in V6. If it is more than 0.25, it is pericarditis, less than 0.25, it is ERS. And there is no reciprocal changes, and agar CT angio kar rahe to no kuch nahi aayega. And there are different types: type 1, type 2, type 3. Type 1 usually anterolateral changes will be localized to lead 1 AVL V4 to V6. Type 2 mein it is inferior ERS, and type 3 mein global ERS. So I've told that BER is not so benign. So presence of ERS in the inferior leads or inferolateral leads can trigger life-threatening arrhythmias. So which all patients we should evaluate? So if the patient is having, again, if the young patient unexplained syncope, no other symptoms, or if the patient is having any family history of sudden cardiac death at young age, his family में अगर किसी को death हो गया young age में, or if the patient family is having a similar ECG pattern. So not all ERS syndrome needs to be evaluated. Only these 3 patients you have to keep in mind. If there is a unexplained syncope, या फिर family members में history of sudden death at young age, or if there is any similar ECG pattern.
So there is one question for Hari. Hari, there is such a syndrome, that is a duration syndrome, and on top of that, there is a power there is a state elevation. How you differentiate the state elevation and the utilization process? True state elevation. What is the
So I'll read. A 16-year-old young athlete collapses during a soccer game after being stuck in the chest by a ball. Bystanders called for help. Monitor shows VT. AED was given. Shock given. Patient is ROSC achieved. So this is a typical case scenario of something called as a commotio cordis, traumatic cardiac arrest. So it usually leads to sudden blunt trauma to the chest wall, can lead to sudden cardiac death. Second most common cause of death in young adults after HCM. And the basic pathophysiology is like an R on T phenomenon. The trauma exactly occurs 10 to 30 milliseconds just before the peak of T waves. So during repolarization, agar there's trauma, it will lead to R-round T phenomenon. So it will lead to VF. If the patient receives immediate AED, then the patient can be saved. So if the patient passes away, then the autopsy findings will be normal. Survival rate is increased with AEDs. Usually the problem is that such patients collapse on the ground. They won't be having AEDs. If the AED is there, then definitely the patient will survive. The only thing needed is that defibrillation. So the patient is survived, observed for 6 to 12 hours. Then before restarting sports, do a stress testing or cardiac MRI. Coming to the basic risk stratification, again we are consolidating everything. So we've seen that the most best predictor of sudden cardiac death is the LV ejection fraction. If it is less than 35, ICD implantation is needed. CT coronary angio, most common cause is CAD. So through road karne ke liye. Then ambulatory ECG monitoring in case of channelopathies or for cardiomyopathies. Exercise testing, again in case of HCM. Then programmed ventricular stimulation. Agar if there is inducibility of VT, then we have to consider ICD. Again, prevention of sudden cardiac death is by risk stratification and identifying the candidates for ICD implantation. Then recognizing the signs and symptoms in high risk patients. Then medical management, antiarrhythmic, samiodarone. These are the general indications for ICD implantation. Ejection fraction less than 30, QRS more than 120, history of cardiac arrest in family or prior cardiac arrest, inducible VT on ventricular stimulation, NIHA 3-4 despite GDMT. So again, we've talked in details about the core cardiology concepts. So basically, patients हमारे पास कैसा आता है? Sudden cardiac death means patients will be unresponsive, no pulse. So it all boils down to the ACLS algorithm, which we routinely follow. So most patients जो हमारे पास आता है, they are OHCA, out of hospital cardiac arrest. In hospital cardiac arrest is very rare. So अभी जो हमने देखा है, mostly they will be coming unresponsive since 5 minutes, 10 minutes. So usually OHCA. So according to the ILCOR, they have collected the data. So this is 2017 तक है. So they've shown that if the EMS care is appropriate, then it has increased the survival rate from 2015 to 2017. There is increase in survival rate of OHCA if there is prompt EMS management is given. Aims data I could not find. Ashwin. After OHCA. So again, the rescue therapy for sudden cardiac arrest is the good old ACLS algorithm. So this is for our first sem juniors who joined. You have to be thorough with the ACLS arrest algorithm. So this is basically what is our role in ED in managing sudden cardiac death, followed by cardio review. So take home points is that identify the common cause of sudden cardiac death, must know the ECG variants of Brugada, long QT, short QT, HCM, indications of ICD implantation and our ACLS.